Hello, everybody, and thank you for joining today's webinar. This is the 16th webinar that Palliative is hosting on topics relevant to healthcare teams who are actively leading the response to COVID-19. These webinars are made possible thanks to an unrestricted contribution from Boehringer Ingelheim and their Bridging Hope initiative. Big thanks to them. Today's webinar is entitled Trauma-Informed Palliative Care. We'll begin to explore this in greater detail, what is meant by the term trauma, its effects on our health, and how we can recognize it. Leading today's discussion are two subject matter experts who will be introducing themselves in just a bit, and each will be taking us through a series of slides and engaging in dialogue. Next slide, please, Salwa. Something different from the other webinars that we've held to date is this introduction that I want to make regarding the Canadian Palliative Care Exchange. So the Canadian Society of Palliative Care Physicians and Pallium have launched this new online community of practice, and really want to encourage all of you after this webinar to visit it. And if you don't have time after this webinar, at some point, you can go to cpcexchange.ca. That's cpcexchange.ca. And we're launching this early for the participants for this particular webinar. And we're asking you to join this exchange to continue the dialogue, because what we found is these webinars are very thought-provoking. We get a lot of great questions and comments, and there are many of you that want to continue this discussion after the webinar, and we're facilitating that through this Canadian Palliative Care Exchange, thanks to our partnership with the Canadian Society of Palliative Care Physicians. It's a chance to ask questions, to go deeper in terms of your comments and share your experiences, and really to teach and learn with your fellow colleagues right across the country. So again, please visit the Canadian Palliative Care Exchange and engage further in dialogue. We look forward to your participation on that. So thank you, and thank you to the Canadian Society of Palliative Care Physicians for making this possible. To the next slide, housekeeping. So in terms of our housekeeping items, everyone's microphones have been muted, but that doesn't mean that we don't want to hear from you. We would very much like to solicit your input and your questions throughout the webinar, and you can do that by using the Q&A function at the bottom of your screen. So throughout the webinar, our panelists will be answering the questions that are raised, and I'll be bringing some of these forward to the panel for further discussion. So I really do encourage you, ask your questions, post your comments, to help add to the collective knowledge that we're going to be generating over the next 60 minutes. So thank you in advance for doing so. We would, however, like to ask that in order to respect privacy and confidentiality, that you refrain from sharing specific details on cases or particular situations when you're posting your questions and comments. So thank you for that. We're going to be collecting all of this information. We're going to be collating this input for future reference. The session is being recorded. It's going to be made available on the Pallium website in a day or so. So next slide. So again, I am your host and moderator for today's webinar. My name is Jeff Moat. I am the Chief Executive Officer of Pallium Canada. And on to the next slide. And more importantly, I'm going to let each of the presenters introduce themselves. So let's start with Dr. Sarah Burton-MacLeod. Sarah, over to you.
Good morning. My name's Sarah Burton-MacLeod, and I'm a palliative care physician here in Edmonton, Alberta, where we finally have sunshine after many weeks of rain. And I would actually, because of our affiliation with the University of Alberta, I would like to respectfully acknowledge that I'm presenting to you today from Treaty 6 territory. Specifically, the university is located on the territory of the Papas-Chase and the Métis Nation.
Great.
Hi, and sorry, and I think we're just working on, many of us can't see the slides advancing, but I think we're working on that. Thanks.
Okay.
Oh, perfect.
Okay, and yeah, so I think we could move on. Susan, do you want to introduce yourself?
Sure, my name is Susan Cadell. I'm a professor of social work at Renison University College, which is affiliated with the University of Waterloo. So I'm Kitchener-Waterloo, on the traditional territories of the Haudenosaunee neutral and Anishinaabe peoples, and want to acknowledge that that territory and that presence. And I will tell you more about myself when I start to my part of the presentation.
Okay, thank you so much. On to slide 6. So we've received a few comments. We know the slides seem to be slow in changing. So give it a few moments to catch up here. We're on the slide now, our declaration of conflicts. I'll start first with a description of our organization, Pallium. Pallium is a national nonprofit charitable organization founded in 2000, so we're 20 years old. We're based here in Ottawa, which is where I am, and we're funded in part by Health Canada. So our role is to equip healthcare professionals, healthcare organizations, and communities with the skills and knowledge to provide palliative care earlier, more effectively, and more compassionately to all Canadians. In terms of conflict, I am an employee of Pallium Canada, and none of the presenters have any conflicts to declare. So we'll move on to the next slide. Okay, so in terms of the Canadian Society of Palliative Care Physicians, who are our partners on this webinar, they're also a nonprofit organization. They are funded primarily by member dues and by funds received at annual conferences. And as I said earlier on, they're also a key partner in this community of practice that we're launching today, and hopefully many of you will be participating in. And that has been made possible by support received from the Canadian Medical Association, Scotiabank, and MD Financial Management. So big thanks to those organizations. Okay, without further ado, I believe I'm passing the floor over to Dr. Burton-MacLeod. Sarah, it's all over to you.
Thank you so much, Jeff. So we're really hoping today that this webinar, I should say, will really pique your interest. And for some of you who may have heard of trauma-informed practice, trauma-informed care before, some of you, this may be new. For me, it was something that I really more recently learned of just in the last few years. And I really need to credit my colleagues in undergraduate medical education in Indigenous health, who really introduced me to this whole concept. And then I began reading around it. So, I mean, I'm hoping that this will likewise be something that's really practical and applicable for any of you who are working in palliative care. So today we're hoping to identify types of psychological trauma, be aware of how prevalent it is, and also gain an understanding of what are the long-lasting chronic effects of trauma that come around because of the adaptations that people make following trauma to actually just try and cope and survive. And also to become familiar with the trauma-informed approach, know where it might be applicable, and in particular, not just in palliative care, but also during this time of COVID-19. And I'm also really looking forward to learning from Dr. Susan Cadell about post-traumatic growth, which is something that I'm really keen to learn about myself as well. Next slide, please. Thanks. So to start with a definition of trauma, and this is from the Trauma-Informed Practice Guide, which I would highly recommend for any of you that are interested as an additional reading resource, as recommended to me. Although it's from 2013, it was a publication from the British Columbia Mental Health Board of the province, and it's really actually fantastic in terms of its clinical applicability. So essentially, in terms of the definition, they say that trauma are experiences that overwhelm an individual's capacity to cope, often something completely unexpected and something that can be potentially very devastating. Next slide, please. Now, of course, there are a number of types of psychological trauma. There can be single incident trauma, where there's a single unexpected and overwhelming event, or there may be more complex and repetitive trauma, such as ongoing abuse or domestic violence. And it often involves being trapped either physically or emotionally in a situation. And then the third type I'll reference here, along with two more types on the following slide, is developmental trauma, where there's an added component where this occurs often during early childhood, can involve abuse, neglect, and unfortunately often occurs within the child's caregiving system, and so can really affect brain development and growth. Next slide, please. Thank you. The two additional types of psychological trauma are intergenerational trauma, where those living with people who've experienced trauma themselves can pass on their coping and adaptation patterns that they've used to survive. And that can have emotional and psychological effects on those who live with them. And then historical trauma, of course, alludes to a much greater, larger picture where there's cumulative psychological and emotional trauma that occurs across generations. So examples of this would be colonialism, genocide, slavery, war, other very traumatic things. And of course, intergenerational trauma would be a form or an aspect of historical trauma. Next slide, please. Oh, thanks. Sorry, Robin. Can you hear me a little better now? So in terms of the prevalence of trauma, 50% of all Canadian women and 33% of Canadian men have survived at least one incidence of either sexual or physical violence. And in fact, the data shows that approximately 9.2% of Canadians actually meet the criteria for PTSD, which, as we know, is one particular psychiatric diagnosis, but indicative of potentially the overall prevalence of trauma. And in fact, if you look across a lifespan, the data suggests that, in fact, the majority, up to 76% of Canadian adults, report some form of trauma exposure during the loss of a lifetime, including, for example, the unexpected death of a loved one, sexual assault, seeing someone very badly injured. Now, of course, this is not only a cumulative effect, but it also depends on when the trauma occurs. And as alluded to before, what we know is that if you experience trauma during childhood, it can be particularly difficult and have particularly long-lasting effects, which brings us to what I wanted to talk about in the next study, and which is on the next slide, please. So some of you may have heard about this before because it was quite a sentinel study, but essentially it's the Adverse Childhood Experiences Study, which was done by joint Centers for Disease Control and Kaiser Permanente effort in the 1990s. So it's some years ago now, but it was a large study, over 17,000 patients in Southern California. And what they did is they had them complete surveys, not only on their current health, mental health, as well as physical health, but also on adverse childhood events that they may have experienced. And what they found was, in fact, these are actually quite common. 2/3 had at least one experience. And of this population, 1 in 5 had 3 or more experiences. And if you think about this being a cumulative effect, you can see that already having 3 adverse childhood experiences or more, that's got to make a difference potentially, right? So in fact, they did verify that this is almost like a dose response type relationship where there can be negative health effects over the entire lifespan. Next slide, please. So listed here from that same study are the types of things that those who experienced adverse childhood experiences struggled with later in life. So whether it's substance use disorder, including alcoholism and subsequent sequelae from that, they were more likely to start smoking earlier and to develop COPD, more likely to struggle with mental health issues such as depression, to experience intimate partner violence, sexual violence, to struggle academically with work performance, and then of course, as a consequence of that, to have more financial stress. And there were many more as well. This is just a small portion of the list. Next slide, please. And for those who are more visual like me, I really like this diagram because, again, it just really illustrates how adverse childhood experiences, which you see at the bottom of this pyramid, can lead to not only disrupted neurodevelopment, but that the sequelae of that are that there is impairment in multiple domains, social, emotional, cognitive development, that then make you more likely to have health risk behaviors, such as those mentioned on the previous slide, which lead to further issues and often early death. Next slide, please. And here again are the types of domains where there's a deleterious effect potentially. Now, I should say that, of course, every person is different and everyone will experience this on a continuum in a slightly different way. But these are some of the things that can develop for people who have experienced adverse childhood experiences. And they include, of course, as you see, not just physical, but emotional, spiritual, interpersonal, and behavioral as well. And I think it's important to highlight that many of these are an attempt by people who survived trauma to try and learn how to cope and adapt. Even though their coping mechanisms were completely overwhelmed at that time, or times plural, now they've got to try and carry on with life. And these are some of the things that this has led to, and the difficulties that may now be expressed in different ways because of it. Next slide, please. So this brings us to our main point, which is, what is trauma-informed care? So what we would want to do, of course, at all times is to try and address our patients' healthcare needs the best we can. But in this particular case, we also need to be aware of the risk of re-traumatization, and we want to really try and avoid that. And so we want to, hopefully this webinar will help you in terms of developing a sense of, who might be at risk of having experienced trauma, and how might this lens help us to understand, rather, hey, what's wrong with this patient? How come they aren't compliant? Or all these terms we used to use when I was in training that we shy away from now. But rather, what happened to them? Why are they behaving in this way? And how can I really help? So in terms of recognition, as I mentioned, the signs and symptoms of trauma can really be variable. But certainly I think it's important to know what they can be. And to highlight again that certain behaviors, being coping mechanisms for survivors of trauma, may lead to things like inconsistent clinical care and not showing up for appointments or not following through. And so I think potentially being able to recognize that in advance can really be very helpful in communicating with patients and knowing how to best support them. And also to know that there are certain groups that are, of course, at higher risk of trauma, including these that I've listed here as well. Next slide, please. So what are the elements of the trauma-informed approach? Well, there's sort of three key elements, really. And the first one, of course, is building awareness. Now, part of that is self-awareness, to really have a think about, what are my assumptions about who is likely to experience trauma? What are my assumptions about what it's like to survive and recover from trauma? What are, things I've experienced in my life? Are there things that could potentially be triggers for me? And how would I cope with that? And how can I best support people who may have gone through difficult things? And also, what are the things that I know about vicarious trauma? Because that comes out of the literature around those who supported and treated people who survived trauma. And we know that we've talked about it, I think, more and more through the years in terms of our palliative care practice and the daily suffering that we see in our patients and how that can affect us. So we'll talk about that a bit more later as well. And also the different levels of intervention required, and also to be aware of the barriers that may be present. And I think we're going to allude to this a little later as well, but just to say that, of course, some trauma, unfortunately, the healthcare system may have been part of that problem. And I'm speaking here particularly around for any of us that, have become in more recent years, unfortunately, aware of the issues with the Indian hospital system and the systemic racism experienced by many there. I'm often very mindful that for some of my patients, just walking through the hospital doors can be potentially very traumatic for them. Safety and trustworthiness is also very, very important, because for many people experiencing trauma, it was a great breach of trust and an abuse of power in a very close relationship. And so gaining trust is key, but also more challenging for those reasons. And the importance of language, framing why are you asking this sensitive question and how this is going to potentially be helpful going forward. An opportunity for choice is really key. And the recommendation is that we be specific about that as possible and as explicit as possible. So saying, I want to know what your views are on this. And, this plan may not be for you. You know yourself the best. So I would defer to you on that. Or please let me know if you need to take a break, or if this is too much. You can choose to pass on any of these questions. These are the types of things that can be helpful. And then, of course, next slide. Thanks.
So Sarah, I know we've had a couple of comments. I think the audio in some cases, some people are having a hard time hearing you. So if you can project your voice a little bit louder, that would be wonderful. Thank you so much.
Thank you. Yes, I'll definitely try and do that. Apologies. So the next slide is around disclosure of trauma. So does trauma-informed care require disclosure of trauma? And the answer is no, it does not. Using the trauma-informed, oh, good, thank you. The sound is better. Using the trauma-informed approach does not necessarily require disclosure. And this is something that I've had to do a little bit of soul searching about. As a palliative care physician, I often really feel quite fulfilled when patients disclose things to me that are very personal in nature. And I think to myself, oh, they really trusted me. I must have done a really good job today. And so this is difficult for me because I naturally feel myself wanting to know, but I just have to remind myself that this is not about me, it's about my patient and what is most important to them. And I have to set aside my need to know and my desire to benchmark how I'm doing to what is most important for their care today. So rather than that specifically, it's much more about, I think, relationship building than a specific treatment strategy. And just as a reminder, and I think Susan will talk about this more, but the word trauma-informed approach is not the same as treating trauma. And in fact, if you were to even consider specifically inquiring about trauma, then you really have to be prepared and have the resources to respond. Also, just a general note about documentation, because some of the things you may discuss, particularly if trauma is disclosed to you, then it could be quite sensitive information. So one idea is to run the wording that you're planning to use by the patient just to see what they think of it and how much information is only recorded in terms of what you and the healthcare team actually really need to know. Other things don't have to be recorded. Next slide, please. How about the palliative care setting then? Well, I tried to look at this, and in all honesty, I really only found one article from Gerontology, which I've included in the references. But essentially, they had done a literature search extensively and turned up 2 articles, and they were both on veterans who had experienced PTSD and also had palliative diagnoses. But there weren't any other specific mentions of trauma-informed care in the palliative care setting. However, in this one article, their suggestion again was just to be aware of the pervasiveness of psychological trauma and realize that the additional medical interventions and even being handed a palliative diagnosis may in fact be additionally traumatic. And then of course that the symptom burdens that our patients experience may be compounded if they've experienced trauma in the past. And of course the intersection between suffering and psychological trauma and the low overlap there, as well as the patient's pain experience and pain expression may be colored by some of these life experiences as well. So to bear this in mind. Next slide, please. We wanted to mention too, of course, this is the time of COVID-19. And I really liked the quote that I found that I mentioned here, that really we often, I think, feel that this is almost a tsunami of suffering, that this is yet one more layer for our patients and families of suffering that they have to undergo at a very difficult time. There's the additional stress of uncertainty. Many families and patients are struggling with finances, and a lot of people are afraid to seek medical attention because of fear of contracting COVID-19. And I think many of us are finding in clinical practice that there was a period of time where people were staying away and then started to present, but very late and with very widely spread disease and quite ill. And certainly in many of our jurisdictions, visitation policies have had to have an impact in terms of how present the family can be physically with patients who are palliative. And that has been an additional layer of suffering that we've been able to see as well. And of course, there are other things that are happening during this time. In my home province of Nova Scotia, of course, there was that terrible mass shooting. And I think the death of George Floyd in the United States and the whole movement around that, while important conversations, I think it has been a time where there's a lot of emotion, heightened emotion, and a lot of things coming to the forefront that can be additionally stressful for patients and families too. Next slide. And what can be the effect on us? And the quote I included here is that really the risk of compassion fatigue, moral distress, and burnout has never been higher than during COVID-19, is what people are saying. And I think that that resonated with me, and I think potentially with some of you as well. Again, I allude to the concept of vicarious trauma and that cumulative effect of seeing suffering every day and now having this added layer on top of it. And it can really have an impact on us both professionally and personally. So I think it's just worth mentioning for all of us to be aware, right? And to spend that time just to think about how this is affecting us and to acknowledge that that is okay to feel that, to counter some of the isolation we may feel, and really take a look at what can we do for self-care and how can we maintain optimism. And specifically around trauma-informed care and COVID-19 and palliative patients, I think optimism is very important. And I think I'll defer to my colleague on some of the learnings around that as well. And in fact, what we know is actually our interactions with our patients can in fact be sustaining. And so not necessarily that they're contributing to vicarious trauma, but we just need to really be aware of that. Next slide, please. So what can we do? Well, become more informed. Well, that's why we're all here today. And also recognize those who would be higher risk of trauma. Recognize the signs and symptoms of it, recognize the link, and potentially help guide our patients, if and when they're ready for this, to also recognize the link between what may have happened in the past and the traumas they've survived and what may be happening now. Can be very important in their learning and in their treatment. Remember that information is really a need to know basis, and that applies to documentation in particular, that disclosure of trauma is not necessary for trauma-informed practice, but what is necessary is that relationship. Creating an atmosphere of safety and trust is very important, as well as collaboration. And then also the recognition of suffering and how physical symptoms may present and be colored by this. And recognizing that, you know, sometimes I think for many of us in this field, we just see that suffering can just be so disproportionate at times. And that can be difficult. And it can be difficult for us to see. But if there's a way in which this will help us meet the needs of our patients and support them better, and potentially, you know, ensure that these inequities, you know, things that happen to them through no fault of their own, often in very early childhood, that have left such a difficult path through life, if there's a way of helping to address that and make sure that it doesn't continue and inequities are not perpetuated, then that's something that we certainly want to do. Thanks so much. I'm going to hand over to my colleague now with the next slide. And again, apologies for the sound.
Listen, Sarah, thank you so much. Great presentation. Susan, just before we hand it over, a couple of questions from the participants, and thank you participants for your great questions and comments. Very much appreciated. A few things. One, someone asked if you could define the term LGBTQ2S+. And the other question is, do you think since this cultural change climate has unfolded, since the two articles that you referenced were produced, do you think there'll be more research in the future to explore the impact of racial violence and enslavement on those who are now faced with palliative diagnosis?
Thank you. To the latter question about, do I think there will be more literature in the future? I really hope so. I think that this is something that we really need to look at everywhere. And I think that anti-racism is so important for all of us to be aware of our own unconscious biases, I should say, and to hopefully be more aware of how systemic racism is affecting so many of our patients. And I really hope that there's more literature specifically here in Canada, because we know that we have a lot of issues here too. And I think many of us look at the States and think, oh, well, you know, haven't they got issues? Well, we have too. And I think that we really all want to be as open as we can to that. I don't know if that helps. And sorry, the first question was a definition of LGBTQ2S. I might not claim to be an expert on this by any stretch, but as I understand from friends and colleagues, that gay, lesbian, bisexual, queer, and two-spirit also encompasses a larger community who may not fall into any of those previous categories. And so we want to make it, I think, as inclusive as possible. I don't know if that helps.
Yep, and the word transgender in there as well. So thank you.
Sorry. Thank
you.
No,
perfect. One last question. It was offered by one of our participants. Is it helpful or harmful when we do intake questions from clients to ask about previous trauma? This could be triggering for clients, and not sure it's always if always as a practitioner that they're trained to help unpack everything.
Yes, and I think that that's something I struggle with, as I say too, is that I'm trained to help unpack and to look at whole person care. And so this was something that really gave me pause. I would say it depends on the nature of your relationship and to some extent on your style of practice. So for example, at the moment where I work in acute care consults, I often will see patients and families only once. And so it is very difficult within that time for me, I think for most situations, to gain the level of trust and establish the safety that I think that I would need in order to be able to ask them about that. However, I previously worked on the palliative care unit here in Edmonton and also at Briere in Ottawa. And because we would get to know our patients over a much longer period of time and be able to develop more of that rapport and relationship, I would say that I was more likely to have those conversations and be able to ask that question, excuse me, sorry, there than I was in my current practice. Now, sometimes, even in my practice now, I may meet people once and they may divulge and disclose things, but I'm less likely to ask for that exact reason that I don't want to re-traumatize, and asking at a time where they're not ready and it's about our agenda could really be quite damaging.
Thank you. Several other questions. We're going to move those to the end so that we can get Dr. Susan Cadell to take us through her presentation. Dr. Cadell, over to you.
Thanks. Thanks, Sarah. It's one thing to see the slides that someone's going to present, and it's wonderful to actually hear the presentation. So my name is Susan, and I use the pronoun she, her. I start this way to set an example and want to build on the question about defining LGBTQ. To us. I am the parent of a queer child and highly recommend reading LGBTQ Inclusive Hospice and Palliative Care by Kimberly Acquaviva if you have not read it. It is an excellent book and needs to do a slightly better job in terms of trans folk and genderqueer folk, but is an excellent resource. And I'll add that to the list of references when we send out the slides. So I just wanted to add that piece. So I start with introducing myself and situating myself because, as you've just heard, trauma-informed work, part of it is about building trust and building relationship. Well, we do that by starting with ourselves and recognizing ourselves as the tool for doing that. I have a background, as I said earlier, I'm a professor of social work. I have a background in social work. I worked for many years in family counseling with family violence and sexual abuse, and worked on a sexual assault team in a hospital where we were responding when someone was sexually assaulted, and did a great deal of work in the 90s around HIV and AIDS, and then did my PhD work around HIV and AIDS. So I think in some ways, when I think about trauma-informed care, I think I have been doing trauma-informed care before I even knew the term. So this first slide is about just to underline the point that's already been made, that it's really important to understand that trauma-informed care doesn't mean that you're treating trauma. And I just want to briefly address the earlier question about putting a question about trauma on a questionnaire, an intake form. It is a place for it. It may be that you want to put it as an optional question to answer or something like that, but that if you do ask the question and people say no, you need to, trauma-informed care means that you need to be prepared to actually hear about trauma later on, even if the answer was no at intake. So that's the nature of trauma, is that it often is not disclosed until trust is built. And I'd like to go to the next slide, please. So, like my introduction, like my comments earlier, language really matters. Language is how we communicate that we care. Language is how we, provide, explain what we're doing when we're delivering care to patients and families. And so the really sort of paradigm shift of trauma-informed care is thinking about what happened to people. And rather than thinking about what's wrong with them. And, you know, we work in a healthcare system that is naturally focused on the pathology, and palliative care is already moving out of that anyway, because we do whole person care, because we work in teams and we come to this work with a different, often a different set of values and approaches to care than sort of the traditional medical model. And so this piece of it, this shift is probably not as big for palliative care practitioners as it might be for some others. But so I just, you know, if you want to type into the chat box and put in anything, I put up on the slide the term of non-compliance and non-adherence, which, you know, in the HIV/AIDS world, we heard a lot, and I personally am very bothered by, because that's just pathologizing the person. But another term that I didn't put on the slide, yeah, resistant to care. Thank you. I knew somebody would have something. The other term that I avoid is the term of loved one. And I do a lot of research and thinking and writing about grief, and we tend to use the term loved one when someone has died. And I think it's really important to think about the use of that term, because relationships are complicated, and people often care for and care about others, but it's not based on love. It's based on all kinds of other reasons. Think about a child caring for an abusive parent. They might be doing that caring, but they might not love that person. And so when we talk about that parent as a loved one, be they alive or dead, you know, we are reducing that relationship to an emotion that may not be present in that relationship. So if we can think about different terms for loved one, like the person, then, you know, that's another approach. That's another place where language matters. Thanks, Elizabeth. Thanks. Yes, people important. The person who's important to you. That's in a general sense. Absolutely, there's a good general term. Or the person who's ill. If you're talking about someone, you know, someone who's the caregiver, let's call it what it is. If it's the person who died, then let's just say the person who's died. So the other aspect of trauma-informed care that I just want to bring out, and what I've done is pulled a number of quotes from the article by Sweeney et al. So you know, it's in the reference list, and I think it's really important to remember that trauma-informed care is also about changing our organizations. And one of the things that I think about here is who gets to have palliative care. So my real introduction into palliative care came in Vancouver when I was working at the University of British Columbia and working with Vancouver General Hospital and, no, St. Paul's Hospital, sorry, not VGH. And we were delivering an interprofessional course on palliative care. And someone pointed out to me a very striking picture of the, at the time, and I haven't been back, so I don't know what it's like now, the palliative care ward was on the same floor as an HIV ward. And they were so different. They were like side by side, and they were lit differently, and they had different feelings. And, you know, so the person who pointed out to me pointed out that there didn't seem to be any reason why the folks who were on the HIV/AIDS ward wouldn't be getting the same kind of atmosphere and care that folks were getting on the palliative care ward. So I think that's one of the things that we need to think about in palliative care is who's there. And there was an earlier comment about Indigenous peoples being more susceptible to the kinds of trauma that were being listed. And absolutely, and intergenerational trauma is incredibly important to understand. So what that means is that it may not be that I'm traumatized by something that happened directly to me, but I'm traumatized because it happened to my mother and my grandmother, or my father and my grandfather. So, you know, I think that's, that we need to be thinking about our organizations and who is in our organization and who is not in our organization. And again, I'll put in a plug for the Aqua Viva book because I think she addresses that extremely well. So the next slide. So David Kuhl was one of the people that I worked with when I was in Vancouver, and he was part of the palliative care course. And it was at the time when he was doing his doctoral work, and he talked a lot about iatrogenic suffering. And he defines it as the pain and suffering inflicted by physicians. And I think it's a term that that goes beyond physicians. We should never ever assume that pain and suffering is only due to physicians. Social workers, you know, I could do a whole webinar on the ways that social workers have inflicted pain and suffering, but we won't get into that. But all of the members of the healthcare team need to be aware that iatrogenic suffering is a possibility. And it may not be that I have treated this person badly, but I have to work to gain their trust because they've been treated badly or traumatized in the past. So it's really important to remember that aspect of it. And, you know, I think about facing, you know, a life-threatening illness, facing the death of someone that I care about, and thinking about COVID. And I think at this point in time, all of those kinds of aspects, palliative care in and of itself and the COVID pandemic, have the vast potential to be exacerbating existing trauma. And so that it really makes the reason to be trauma informed right now even more critical. So next slide. And this has been touched on already. We need to build trust. That, again, language and trust are the tools. And so this particular quote is about openness and transparency and respect, and not and trying to mitigate. Sometimes we have a relationship where we have power over. Like when I'm a professor with students, I have power over them because I'm giving them grades, but I try to mitigate that as best possible. And so when we can be aware of that and try to work with that and address that as much as possible, as much as humanly possible, then that's going to help to gain trust. The next slide is also about trust. So this is about making people feel emotionally and physically safe. I would say safer, not safe. My HIV/AIDS days, you never had safe sex, you had safer sex. And I think, you know, I try to make a safer classroom, but I'm never going to make a safe classroom. But you know, it's about relationship, and it's about the you know, the aspects of psychological, emotional, social, gender, and cultural safety. And so we need to be, as professionals, we need to be competent in all of those areas, and that's part of the lens of trauma-informed care. So the next slide is about post-traumatic growth. So the one of the earlier slides had the stats about PTSD, and it's fewer than 10% of people who are exposed to trauma who actually develop PTSD. It doesn't mean that people aren't traumatized, but they don't have a sort of illness definition of trauma. But what that says to me is also what, you know, what happens to the other people who are exposed to trauma. And one of the things that happens is the possibility of post-traumatic growth. it is not an automatic. I want to be really clear about that, but it is a possibility in the realm of things that I think it's really important to have as part of our knowledge of, in order to be trauma informed. So Tedeschi and Calhoun coined the term. They're two psychologists who had been doing a lot of work with widows and with grief, and they realized that there was a whole lot of positives going on that they hadn't accounted for, and so they coined this term. So the next slide is super complicated, so I'm just going to show you the whole thing and then go on to the next slide, which is the important part of this is the model of post-traumatic growth. And what's important about this is that in growth, this is the end point of post-traumatic growth, there is still some enduring distress from the trauma. There may be growth, which is, these 5 domains, narrative development and wisdom, which is this sort of cyclical thing, but there is still enduring distress. And I can't stress that enough, that when someone has grown from an experience, it doesn't erase the distress, and there is still ongoing distress. So that's a really crucial piece to understand. And in the next slide, I just want to show you that this is actually from some research that I did with parents who were caring for a child who was living with a life-limiting illness. So we often characterize, parents and childhood illness as and pediatric palliative care as being kind of the worst kind of experience. But these parents experienced growth, and it was mediated with their sense of well-being and the meaning that they were creating in their caregiving and the understanding they had of the caregiving. So again, that reference is in the slide, and if anybody has any trouble locating the article, I'm always glad to provide copies of it. But I put it up as an illustration of, even in the midst of really stressful and potentially traumatic circumstances, that these parents were still having experiencing positive aspects. They were still talking about ways that they had grown and were growing from the experience. And so, just as an aside, one of the things that we did in this study was we only measured stress because we didn't think that the parents would be talking about trauma. And in fact, they were talking about trauma, and what they were talking about, because we did interviews with them as well, was the trauma of the way that they received the diagnosis. So just to circle back to that idea of iatrogenic suffering, that sometimes the suffering is inflicted by the words that we use or we don't use. And in this case, with these parents, it wasn't just physicians. All of healthcare was all of their numerous professionals were involved in those kinds of negative experiences, but they were also talking about trauma. So next slide, just to start to wrap up so that we can get to some questions. Be prepared to ask questions. Be prepared to ask questions and to continue to ask questions over time. Identify your pronouns, because as someone said to me once, if I identify my pronouns to you, most people won't even notice. Some people might think it's a little bit weird, but the people who don't present as their pronouns are going to be relieved that this is a safe thing to do. And we're doing it more and more, and we're normalizing it more and more. And so that's really important. Using neutral language. So when you have a woman in front of you, don't assume that she has a husband or a boyfriend, or so use neutral language like partners. Use neutral language like the person that you care about, or the person who's died, rather than assuming relationship or assuming emotions. So think about the language that you use and try to sort of neutralize it. And there's the loved one there. asking open-ended questions, and when you ask the same question at different times, you might get different answers as the trust builds. And I want to add that it's really important to allow time for stories. It's, again, the way that we make relationships. So tell, in as much as possible, and we all have time pressures, and sometimes what you need to be saying is, I only have this amount of time right now, but I'd really like to do X or Y, or is there anything you want to tell me? And and stories can be so important. And so I just want to show you a couple of slides. So the next slide is a story. And I did some research on, can we go to the next slide? I did some research on memorial tattoos, and this tattoo tells a story. And one of the things that I would really like to see is all healthcare professionals asking people about tattoos. This from this image, you would not know that this is a memorial tattoo. And this memorializes a son who died by suicide. And the stories that go along with this image are incredible. And the next slide is one more tattoo. This one is reminiscent of the idea of loved one. This is a tattoo that memorializes her dad. This one actually looks a little more memorial type, but actually tells the story of growth and transformation. And there's a fantastic story behind this tattoo. And so I think it's really important. It's one of the vehicles that we can use as more and more people have tattoos. And in my study, we had not just young people, we had people in there, loads of people in their 50s and 60s. I even interviewed an 80-year-old. So it's not just young people that get tattoos. So that's one vehicle for asking people to tell stories. So I'm going to leave it there, and we can go to questions.
Great, thank you, Dr. Susan. Great presentation. And I know just based on what you presented, you've answered a few of the questions that have come through the Q&As, but let's look at a few more here. There's a specific question around any literature that exists regarding fetal trauma. Do either of you know of any off the top that come to mind?
Fetal trauma as in FASD, or working with people with FASD, or fetal trauma as in when pregnancies aren't carried to term?
Yeah, it wasn't specific in the questions, so
okay.
If there's either, certainly we bring forward when pregnant women experience trauma.
Well, in the PEDS palliative care world, certainly the sort of beginning age of intervention, has been moving earlier and earlier and earlier, and so working, pediatric palliative care now is working with families when they're pregnant, because for various reasons. That can be, pregnancies that sometimes they know that they're not going to go to term, and those kinds of things. So that is there's certainly practice and work there. I don't know if you have anything to add, Sarah.
Thanks so much, Susan. I don't practice in pediatrics, so I really don't have anything to add. I'm sorry. Only just that, I guess there's that intergenerational piece as well, right?
John asks, Susan, could you share some examples of approaches you use to mitigate power imbalance?
That's a good question. I think articulating what our position is in relation to people. So in the classroom, I talk about, yes, I'm going to have to give you grades. This is the way, this is my role. As a healthcare provider, I can't really speak for being a physician, but physicians have certain roles, you know, nurses have certain roles, social workers have certain roles. Like that, I have a responsibility as a social worker, for instance, to report harm if I hear about harm. And you know, to be really clear, I don't need to be reporting past harms. If, like, you know, if somebody's telling me a story from, you know, from many, many years ago, unless unless there is potential for someone else to be harmed now, then, you know, I don't have the need to report that. But that's one of the aspects of the role of a social worker that can affect what people choose to tell me or not tell me, right? And so if I can articulate the aspects in which I have power over, if I have it, in whatever role I'm in, that can help mitigate that, because it gives people the choice. It informs people about what's going to happen if they disclose something to me, and so that's again, it's about language and about talking about being clear about the relationship.
Thank you. There was another question here I thought was interesting is, do you have any suggestions around how we handle HCPs or HCP organizations who do not feel that operating from a lens of TSC or trauma-informed care, I guess, is responsibility of nurses or doctors? In other words, they say that's a social worker's job.
Well, I guess if I could speak to that, I think, you know, the nature of palliative care and the beauty of what we do is that it's a team approach, and none of us can function without the other. And so I personally think that this is everything that affects all of us in the team, and it's our responsibility for each of us to appreciate the lens. And I think because we all have different roles and responsibilities, and we have different areas of expertise that we bring to the table in a collaborative way, I think it will actually function better as a team if we can use a similar lens as well.
Good, thank you.
Yeah, and I just very briefly add to that it is also about organizations writ large. And so, you know, physicians and nurses are part of those organizations, and that because trauma-informed care is also going to take care of the healthcare workers differently. So that's it's an argument to try to get out of responsibility, in my opinion.
All right, thank you. And I know we've been given the 3-minute warning, so I'm going to just pick and choose a few other questions here. Vincent asks, you know, help him understand what he needs to do to address my pronoun usage that mitigates trauma.
That is one aspect of normalizing the experience, recognizing that, you know, violence against gender minorities is a reality, and it's one small way that's really easy, and to kind of normalize the identification of that, so that, you know, in a sense, everybody's doing it, and we're not taking it for granted. And so that we can also help correct one another when wrong pronouns are being used. So it's one piece of the puzzle. It's not going to make you trauma informed if you're doing that, but it's one tiny piece of that, because violence and microaggressions against people who are gender non-conforming is very real.
Great. Another question here. This is someone just looking for some practical, pragmatic information that could assist them with some of the language when we're trying to express what we used to refer to as non-compliant or non-adherent. So when we prescribe something and the patient doesn't follow this, we do need to record this in a non-judgmental way, but it is still important to record this.
Well, and I think for me, it's, and this comes out of, you know, my HIV/AIDS days, is that what needs to happen is a reflection of why that's not happening. When that regime was recommended, you know, was it explained well? Did it take into account the person's lifestyle and, you know, or wishes or whatever the situation is? And then, you know, how well did we communicate that? Or did we just hand over the expectations? You're muted, Jeff.
Of course I am. Sorry, folks. I just wanted to say quickly on behalf of Palliative to thank our esteemed panelists for the time that they've invested in making this webinar happen. Great dialogue, great questions. Thank you to the participants for posting these. Let's keep this discussion going. Please visit cpcexchange.ca. This is exactly the kind of dialogue we want to get into and why this online community of practice was created. So please join us. We're very appreciative, panelists, for the content that you've shared with us today. Thank you to all of you who participated in this webinar for taking time out of your schedule to attend it. I hope you found it of value. It certainly seems so based on the input. And we're looking to produce more of these webinars, of course, going forward. You know, following the conclusion of this meeting, you're going to be sent an email with a link to provide feedback on today's session. Please share your feedback. It's the only way we're going to improve these webinars. We do appreciate that. Thank you. Have a great rest of your day. And I wish everyone a great weekend. Take care.